So this is our third tutorial on Krok 2 2016 booklet. Krok 2 2016 booklet. So let's not waste much time. Let's just start right away. So we have a 16-year-old adolescent who has been hospitalized with complaints of uneasy nasal hemorrhage and unbearable pain in his right elbow joint. There is large joint is enlarged and disfigured. The skin over the joint is hyperemic. Arthropathy signs can be observed in other joints. Pulse 90, blood test, that hemoglobin 130, color index is 1, leukocytes, platelet is 220, ASR, Lee-White coagulation time, the start and the end. What drug would be most efficient in the treatment of this patient? So first of all, who can tell me the diagnosis we are looking at for in this patient? Who can tell me the diagnosis?
Hemophilia?
Exactly. So over here, you are looking at a problem with what? Hemophilia. And this is one thing that I've realized about questions when it comes with hemophilia. They start adding coagulation time to it, or they begin to write coagulation time to it. So assuming you don't even know the coagulating time or the normal coagulating time for, hemorrhages or for bleeding or for coagulation, just know that they want you to start thinking of something what close to that area. So now in this case, we are having hemophilia as our possible diagnosis. What is the method of treatment? There are two ways. One is what? Who can tell me? One is by the use of what?
Fresh frozen plasma.
Fresh frozen plasma or
cryoprecipitate.
Exactly. So over here, your best answer will be what? Will be A, obviously. Oh. Who is? All right. Someone's microphone is on. Can you kindly mute it? I think it's Blessing. Blessing, can you help me mute your microphone? Okay. A 67-year-old man complains of dyspnea on exertion, attacks of retrosternal pain, dizziness. He has no history of rheumatism. Skin is pale, acrocyanosis. There are crackles in the lower lungs. Systolic trill in the second intercostal space on the right. Cause systolic murmur conducted to the vessels of the neck. Pulse 130-90, heart rate 90, regular rhythm. The liver extends 5 centimeters under the edge of the costal arc. Shin edemas are present. Specify the suspected valvular defect. So definitely the presence of edema always draws your attention to some specific areas of the body or specific organs of the body, like the heart, like the liver, the kidney, and the GIT. Now, every other thing here is telling us we are obviously having a problem with the, with the heart. So definitely it's a problem with the heart. So over here, specify the suspected valvular defect. And over here, we are going to suspect aortic stenosis, especially when systolic murmur is conducted on the or to the vessel's neck. Systolic murmur is present on the neck area. Don't forget how the arc of the aorta is. It is somewhat close to the neck area, isn't it? When you draw the arc. So the chest, upper part of the chest. So sometimes it can be felt around or when conducted around that area. And that's over here. We are looking at aortic stenosis, which simply means there's restriction of blood flow from the left ventricle to the aorta, So basically, that's what we are looking at. So your answer here should be what? Should be aortic stenosis. All right. Now don't forget, the reason they've told you there is no history of rheumatism is to help you to rule out cases of what? Mitral stenosis, if you are thinking of a mitral valve defect. That's the reason why they specifically let you know that there's no history of what? Rheumatism, or no history of what? Respiratory tract what? Infections. When that happens, you are likely to have what? Mitral problems. So here your answer is C. A 24-year-old female teacher complains of dizziness and heart pain that is irradiating to the left nipple. Left nipple. Pain is not associated with physical activity and cannot be relieved by nitroglycerin. And we know cardiac glycoside. That's what we use. Mostly we use for people having what? Acute sort of condition, isn't it? I mean, heart problems. Now, it abates after taking Valocodine and lasts an hour or more. Patient has a nearly 2-year history of this disease. A 2-year history of the disease. Objectively, pulse is that, BP is that, heart borders are normal, heart sounds are clear, ECG shows respiratory arrhythmia, radiograph of the cervicothoracic spine reveals no pathology. Lungs, abdomen are unremarkable. What changes in the blood formula can be expected? What changes in the blood formula can be suspected? Of course, the thing that every other thing is what? Normal. Everything is normal. So although we are having a functional or mental changes, because this is a functional disorder. This is a functional disorder. And in functional disorders or some mental changes, there is no organic changes. And when there's no organic changes, it means that the blood smear will not change. Everything will be normal. Everything will be normal. There's no sign of infection, no sign of cancer, no sign of what? Thrombocytopenia, nothing. Everything is absolutely what? Clear. Everything is absolutely clear. So over here, we are definitely looking at what? At B as our answer. No changes. No changes. No changes. So who can tell me a possible diagnosis in this patient? Who can tell me? So you're having signs and features of heart pathology. However, there's no underlying pathological process happening. Who can tell me? What are you thinking about?
Somatoph.
Exactly. So those guys. All right. So you know it already. So your answer is what? Is B. So assuming that I ask you of diagnosis, you already know your answer. A 51-year-old female patient complains of frequent defecation and liquid blood stricken stools with mucous admixtures, diffuse pain in the what? Is it inferior lateral abdomen? Inferolateral abdomen. 6 kg weight loss within the previous month. 6 kg of weight loss. Objectively, the body temperature 37, malnutrition, skin is pale and dry. But before I continue, who can tell me the differential diagnosis of this condition? Differential diagnosis.
Non-specific ulcerative colitis.
Good. So these things comes to your mind. Some might say yes, dysentery, yes, colitis, and you're absolutely what? Correct. But we analyze and then we arrive at a particular what? Answer, or you arrive at a particular what? Answer due to the presentation. Weight loss or severe weight loss, all of them occur at the sigmoid, or they can all occur at the sigmoid. So abdomen is soft, sigmoid is painful and spasmodic, makes rumbling sound, liver is dense, painful, extends. What is your diagnosis? Definitely, for us to have weight loss, definitely we are going to go in with what? Non-specific ulcerative colitis instead of shigellosis. Because in shigellosis, there is massive diarrhea. And that diarrhea alone will prompt you to go to what? To the hospital quick. That's severe diarrhea. So the weight loss will not be significant as in this sort of case. So over here, we are looking at what? At E as our answer. At E as our answer. All right. We talk about this. We talk about the irritable bowel syndrome, irritable bowel disease. So please, if you are lost, just do your possible best and get in touch with those videos. Chief physician of a polyclinic charged a district doctor with a task to determine the pathological prevalence of disease N in his district. So they want to know the prevalence of a disease. And when we say prevalence, it means how, the occurrence, the incidence rate, basically. We're talking about the incidence rate of the disease. So what document allows to estimate the disease prevalence in the population of a medical districts in the population? So again, over here, we're looking at how rampant or how stubborn this disease is prevailing in that district. So that means both old and new diseases, you have to calculate them, isn't it? You have to calculate them. And now the reason why we are doing these vaccines worldwide, I think I've said it already, why we are doing the vaccines worldwide now is to reduce the prevalence rate. Is to reduce the prevalence rate. So over here, how are you going to estimate? You are going to estimate it by what? Of course, by doing prophylactic examination, or by the use of prophylactic examinations register. And why am I saying this? Or why are we settling on this? We are settling on this because if you give somebody prophylaxis, in this case, vaccine, what we're talking about, vaccine, of course, if the vaccine is working, you are going to know. If it's not working, we are going to know. So that will tell us, yes, this disease is prevailing or it is not. Okay, so after giving the vaccine if it's working, that means the population or the disease population the disease population in the people will also be decreased. And that will mean that you are able to estimate this disease. And it also helps you to know if the vaccine is good or not. So the answer is what? Is E. So now that we are in Ghana, we are being given the vaccine. We'll wait to see if indeed the rate will be decreased or will be increased. All right. Now, a 32-year-old woman complains of dizziness, headaches, palpitation, and tremor. For the last several months, she has been under outpatient observation for increased arterial pressure. Okay, since recently, such attacks have become more frequent and severe. Objectively, the skin is covered with a clammy sweat, tremor of the extremities are present, heart rate is this, BP is 220, 140, heart sounds are muffled, RBCs, ESR, sugar 9.8. What disease is most likely the cause of this crisis? Again, we have discussed this question severally. And we say anytime we have an extreme high arterial pressure with an increase in glucose, usually it is typical for a tumor of the adrenal gland. And if a tumor, then we call it what? Pheochromocytoma. So in this case, we are having a case of pheochromocytoma. So your answer is A. A 45-year-old patient complains of pain in the epigastric region. Left subcostal area, abdominal distension, diarrhea, weight loss. He has been suffering from this condition for 5 good years. Tongue is moist with white coating near the root. Deep palpation of the abdomen reveals slight pain in the epigastric region and Mayo-Robinson's point. Again, positive Mayo-Robinson's point points your attention to what? Who can tell me? Pancreatitis, exactly. So the liver is painless, protrudes 1 centimeter from the costal arch. Spleen cannot be palpated. What disease are you suspecting? And of course, Dr. Kalila has helped us with the answer. So you are looking at what? Chronic pancreatitis. And chronic because this person has been suffering from this for 5 good years. So your answer is chronic. All right. A 58-year-old woman complains of spontaneous bruises, weakness, bleeding gums, dizziness, mucous membrane and the skin are pale with numerous hemorrhages of various time of origin. The lymph nodes are not enlarged. Heart rate 100 BP. There is no changes of internal organs. Blood 3, hemoglobin 92, color index 0.9, eosinophil, staph, segmented, lymphocyte, blah, 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 blah. What index should be determined additionally by a laboratory to make a diagnosis? So first of all, you need to have a diagnosis in your head. So having a diagnosis in your head, what comes to mind? Who can tell me? What comes to mind? What is your diagnosis? Sorry?
Hemophilia.
Come again? Hemophilia. Okay, good. But hemophilia basically will be dealing with what? Clotting factors. Yes. But over here, you are looking at what? Thrombocytopenic purpura. Exactly. That is what you should be looking out for. And if that way, then you are looking at what? The platelet. You are looking at the platelets. You are looking at what? The platelet. Don't forget, from the blood test, almost all the parameters are in normal range. Almost everything is normal. Almost everything is normal. So what is left is for you to check what? The platelet. Check the platelet to see if there's something like that. So over here, your answer should be what? Should be platelet. All right. A 49-year-old patient complains of swallowing disorder that intensified during eating solid food, hiccups, hoarse voice, nausea, regurgitation, significant weight loss. Guys, even before you continue, what comes to mind? What comes to mind?
Also,
Good. So exactly. So definitely,
Cancer.
you are looking at a cancer problem. Exactly, a cancer problem. And we've talked about this, number of times, that with cancer, what you have to do is what? To always look out for your biopsy. Exactly. Look out for your biopsy. So just for the sake of reading the question, let's continue. Now, the body weight is reduced, skin is pale, dry, vesicular respiration, heart sounds are significantly sonorous, heart rate is rhythmic, abdomen soft, no pain on palpation, liver is not enlarged. So what investigation again are you going to do? So definitely you have to do what? Also phagoduodenoscopy with biopsy. So here your answer is what? Is D. Your answer is D. All right. A 9-month-old child presents with fever, cough, and dyspnea. Fever, cough, and dyspnea. The symptoms appeared 5 days ago after a contact with a person suffering from upper respiratory tract infection. Child is in grave condition. The temperature is 38. Cyanosis of the nasolabial triangle is present. Respiratory rate is 54. Nasal flaring during breathing. There was percussion dullness on the right below the scapular angle. Tympanic sound over the rest of the lungs. Auscultation revealed bilateral fine crackles dominating on the right. What is the most likely diagnosis? So again, for the fact that we are having we are having some signs of consolidation, isn't it? You are having some signs of consolidation. Percussion dullness, tympanic sound, auscultation with moist crackles and stuff like that tells you that we are having some signs of what? Consolidation. Signs of consolidation. And one of the major diagnosis or major diseases related to consolidation is what? Is pneumonia. And looking at the pathogenesis of being in contact with someone suffering from upper respiratory tract infection, yes, we could be looking at this as acute pneumonia. Acute pneumonia. Don't forget, with pneumothorax, which of course also one of the signs of consolidation, meaning that something is inside. That one usually it comes as a result of what? When there is RTA or when there's trauma to the chest and things like that. So definitely that one is already out of your mind. And in this question, we're not talking about your voice, necessarily your voice and things like that. That's why we can also rule out what? Laryngotracheitis and so on and so forth. And of course, bronchiolitis, of course, it's also very common in children, but this is not bronchiolitis. This is acute pneumonia. Acute pneumonia. So here, your answer should be what? A. Sorry, should be C. Acute pneumonia. A 50-year-old man who works as a polisher at a combined building factory addressed the factory's sectorial doctor with complaints of general fatigue, sensation of numbness, and pain in his fingers. Pain in his fingers. The skin of his fingers is pale. Reaction to pain, tactile, and terminal stimulus was revealed to be significantly disrupted. No disruptions can be observed with the other organs and symptoms. What disorder are we looking at over here? And I believe that if you look at this question, your mind already will be drawing your attention one way or the other to one kind of disease. Who can tell me?
Is it Raynaud's?
Raynaud's disease.
Good. They are all part of the. Have you heard of vibration disease?
Yes.
Mm-hmm. Yeah.
When you are dealing with what heavy sort of
Metal.
metal that are kind of vibrating. If you don't take care, you might be thinking of something like that. And all of them too, it comes to Raynaud's disease, and they are all part. They all form part of this vibration kind of a disorder. However, over here we are going to be dealing with what we call a hammer disease.
Pneumatic hammer
Yes,
disease.
pneumatic hammer disease. Pneumatic hammer disease. Why?
So
Because we are having what
confusing.
this worker has been exposed to repeated percussion, has been exposed to all of, because it's a polisher, okay? And these people, they normally deals with, how do I even call it? They use what we call a jackhammer. They use what we call a jackhammer, and that is where the name comes from, as a hammer disease, because they deal with these people. They deal with this kind of what hammers in their place of work, okay, and that is causing these kind of what symptoms that we are. I mean, the patient is kind of what experiencing right now. So the fingers become dead, white fingers. Vasospastic syndrome, Raynaud's phenomenon, like you are talking about, all of these things are there. And some of the tools that these polishers they use, apart from the hammer, include the chisel, the road drills, the poundings, and so many machines that they use. So all of these things come hand in hand, and that's what over here we are looking at a problem with what? A hammer disease. Problem with a hammer disease. Hammer disease. And of course, it disturbs circulation in the hands. At the long run, all of these things are disturbing circulations in the hands. That's why we are having all these symptoms showing. So here, your answer is what? Pneumatic hammer disease. All right. 27-year-old woman complains of bleeding gums. This with the life bleeding now. Nasal hemorrhages, multiple hematomas on the skin of her limbs, and on the front of her torso. Extreme general fatigue. Blood, hemoglobin is 64. Why won't you be tired? Erythrocyte 2.5. Reticulocyte 16. Platelets 30. ESR. What approach would be most efficient for treatment of this? But don't forget that reticulocytes should not necessarily be found in the blood smear, right? Even found, it should be less than at least 1% or something like that. So this reticulocyte is telling you that some things are being destroyed rapidly. It tells you that some things are being destroyed rapidly. And because they are being destroyed rapidly, in a way to compensate for the RBCs, what happens is that immature RBCs begin to be seen in the blood smear a lot of times. So that is what we are having. That's the case we are having in this person. But technically, this person is suffering from what we call idiopathic thrombocytopenic purpura. This is the disorder that is suffering from. We've talked about blood. So this is one of the disorders this 27-year-old woman is suffering from. And usually when this then happens, when this idiopathic thrombocytopenia purpura, purpura happens, sometimes the spleen, the spleen begins to produce what we call antibodies. And these antibodies will begin to attack platelets. So I'm talking about the genesis, the pathogenesis of this thrombocytopenia purpura. Antibodies begin to attack the platelets. And when they begin to attack the platelet, they begin to destroy the platelets. And don't forget that the spleen is also involved in removal of what? Dead tissues, or in removal of what? Cells that are dead. Okay, so this spleen, what happens is that one is producing antibodies to destroy or to attack the platelet, and two, it is clearing them out of the system again. So what approach are we going to use to treat this person? Now, don't forget, look at the platelet value. This is what? 30. At least you should have above 140. At least above 140. So again, it tells you that these platelets are being also what? Destroyed. They are being destroyed. A lot of destruction is happening in the body. And to have an efficient treatment, all that we need to do is to remove the spleen. Remove the spleen. So that's what we're going to do. Remove the spleen. So our answer here is what? Splenectomy. Just remove the spleen. That's all. Because even if you give transfusion of platelets, don't forget the underlying cause is not solved. They will still destroy it. So that's one of the pathogenesis of this thrombocytopenia. All right. A 23-year-old patient had taken 1 gram of aspirin to treat acute respiratory infection. After that, he developed asthmatic fit with labored expiration that was arrested by introduction of what? Aminophylline. The patient's medical history is not burdened with allergies. Patient has undergone 2 surgeries for nasal polyposis in the past. Diagnosis, what are you looking at for in this person? Now, this person taking aspirin, the aspirin is leading to what? Asthmatic fit. So your answer is in your question. So over here, we're looking at what? Aspirin-induced asthma. Exactly. Aspirin-induced asthma. A 58-year-old woman undergoing chemotherapy for her oncologic disorder has developed sore throat. This person has developed sore throat. Examination revealed necrotic areas on the mucosa of the pharynx and the tonsils. Many of her teeth are afflicted with caries. In the blood, neutrophilic granulocytes are practically absent. Practically what? Absent. That means, and don't forget, neutrophilic granulocyte, they contain granules. These ones are absent against the background of leukopenia. So that means that we are having what? Low WBC. And with the low WBC, the one that are affected the most are what? The neutrophils. They are affected the most. Now they are saying that leukocytes are presented mainly by just the lymphocyte and the monocyte. Now, what disease is suspected in the given case? What disease is suspected in the given case? And over here, we are looking at what? Agranulocytosis. Again, we are looking at what? Agranulocytosis. Agranulocytosis of the tonsils. Agranulocytosis of the tonsils. And this is simply what? An acute infection that is characterized by severe sore throat, fever, fatigue, and associated with reduction of white blood cells or leukocytes. That is what this condition means. Or agranulocytosis. That's what it means. Sore throat accompanied with what? With extreme reduction of white blood cells. And if you look at our question over here, the blastman has categorically stated it that neutrophilic granulocytes are practically absent. So over here, we are dealing with what? With a granulocyte. I don't know why they wrote agranulocyta tonsillitis, but actually it means the same thing. So here, your answer is A. Your answer is A. By now, you should know what diphtheric is. Lacuna, you know them. All right. A patient complains of a constant dull pain in the perineum and suprapubic area. Suprapubic area. Weak flow of urine. Frequent, difficult, painful urination. Nocturia. The patient has been suffering from this condition for several months, during which urination was becoming increasingly difficult and pain in the perineum has developed. Guy, first of all, what is your diagnosis? I mean, what are your differentials? Let me just start with them. What are the differentials? What are you thinking about?
Urinary tract disease, probably.
Cystitis.
Okay. Exactly. So definitely we are having acute urinary retention. Okay. That is secondary to all the things you guys are mentioning. Okay, to all the things you guys are actually mentioning. So now going further, we're going to know exactly what it is. Now they say on rectal examination, someone's microphone is still on. Let's kindly mute. Nene, your mic is on. Good. All right. So we're having what? On rectal examination, the prostate is enlarged. So again, if you have this at the back of your mind, it immediately sends you to your answer without even wasting time. Dense, asymmetrical, central fascia is smoothed out, the right lobe is stony, density, painless, tuberous. What disease are you looking at for? Definitely, you are looking at what? At a prostate cancer. Prostate cancer. You know it, prostate cancer. So don't get confused about it. A child is 10. The weight is 46 kg. 46 kg. Since birth, he has been gaining excessive weight. Patients, the parents are full-bodied. The child has undergone the following tests: carbohydrate tolerance, level of 17 ketosteroids, blood electrolytes, ultrasound of the adrenal glands, cranial X-ray. Now, test revealed no pathology, so everything looks okay. But look at something. The diagnosis of exogenic constitutive obesity has been made. Exogenic, meaning external obesity, external thing. Okay, external thing. So what direction of therapy should be prioritized? And definitely you are going to what? Do what? Definitely exercising and what? Changing the diet or reducing the diet. Because these are external factors that could cause weight gain. So definitely your answer is there. So reduce the diet or reducing diet and exercising. Reducing diet and exercising. As simple as that. So this is what exogenic. And exogenic means the overweight is caused by consuming more food with less activity. An 8-year-old child with a 3-year history of diabetes was hospitalized in hyperglycemic coma. Specify the initial dose of insulin to be administered. This is Nene's favorite distance. So Nene, your answer is what?
It's 0.1, 0.2.
Exactly. All right. A worker who was involved in firefighting inside the building that stored 2 kg of mercury, has been delivered to a hospital with complaints of emotional expansiveness, palpitation, excessive sweating, body tremor, heart pain. Within 1 day, his condition aggravated. The skin is pale and moist. Patient is depressed. Permanent red demographism, erythema, unstable BP are observed. What drug is the serum? What drug is the serum in this case? In other words, there's poisoning. So what is the antidote? Now we're having what? A metal poisoning. This is what? Mercury. So what? This one, all of it, the Krok one. So what is the antidote for mercury intoxication? And your answer is?
Unitol.
Exactly. So basically it is used to treat poisoning by arsenic, mercury, gold, lead, name them. Even bismuth poisoning. If you guys can remember, Krok 1, there's bismuth poisoning. So all of these things, they can work on them. So Unitol. So your answer is C. During meat testing, Trachinella was detected in diaphragm crura in one of the two muscular tissue samples. What tactics should a doctor choose regarding this meat? We've done this already, and we said even if it is one, you have to what? Dispose this. Yes, so you have to dispose it. We have to dispose it because it's not good for consumption. It is not good for consumption. So over here, we'll not do incineration, but rather what? Technically disposing this meat, to be specific, meat. Yeah. So over here, we should go in for A. All right. A 40-year-old patient was bitten by a stray dog an hour ago. On the left shin, there is a bite mark. The wound is this size. What surgical aid would be most efficient in this case? Now, I don't know why they said surgical aid. It was a surgical aid. That means straight away, we have to take the person into surgery, isn't it? However, what is the best tactics for us to use when somebody is bitten by a stray dog? So basically,
lavage with soapy water.
Exactly. So you wash the place with running water, or you wash the place thoroughly, very well. So technically put, lavage with a soapy water. And this wound seems to be quite big. So definitely you have to do suturing. Okay. But what is the meaning of this retention sutures? This is like a way of enforcing the, how do I call it safe? The sutured place. You are enforcing the sutured place so that no amount of how do I call it? No amount of force can cause it to open again. Can cause it to open again. That is what it simply means. But technically put, you have to make sure that your suturing is well done. Basically, that is just what it is. So over here, we are looking at what? At D as our answer. We're looking at D as our answer. Don't just suture and leave the patient, but, do it properly. So your answer is D. Sometimes the pressure alone can make everything break from each other. A 30-year-old patient has been hospitalized with diagnosis of intestinal obstruction. Let me ask you guys, what is the most common element in the stomach or in your genitals? You can tell me. Okay.
Ascaris.
It's what?
Ascaris.
Exactly.
Ascaris.
Good. So now the surgery revealed the obstruction of the small intestine to be caused by Helminth's ball. What kind of element is it? And over here, we are going to be talking about ascariasis. Ascaria. Of course, in the GNT, we can have ascariasis, we can have hookworm, we can have trichoriasis, we can even have schistosomiasis. But the common one is ascaris or ascariasis. The disease is called ascariasis. So over here, of course, it's called about Ascaris lumbricoides. So your answer, no, this is C, not D. So please, this is C, Ascaris. Mother of a newborn suffers from chronic pyelonephritis. She had a case of is it upper respiratory tract infection before the delivery? The delivery is at term. For a long period, waters were not breaking. On the second day of life, the child developed an erythematous rash. Later, the rash developed into blisters, approximately 1 centimeter in diameter, filled with serous, purulent substance. Nikolsky's symptom is positive. Who can tell me differentials for positive Nikolsky symptom?
Pyelonephritis.
Come again?
Oh.
Pyelonephritis.
No.
No. Nikolsky. Yes.
Steven Jones.
Yes. Yes. Exfoliative. All of these things. It means there's peeling. Now, after the blisters had been laced, erosions developed in their place. Okay. The child is in it. The child's body temperature is subfebrile. What diagnosis is most likely? So, like I said, even though Nikolsky's symptom is positive, which of course, if you want a proper diagnosis, we should be talking about these Steven Johnson's, this how do you call it, exfoliative, and so on and so forth, or toxic epidermal necrolysis. If you guys can remember, toxic epidermal necrolysis, that would have been more ideal. However, impetigo neonatorum is not far from being the correct answer in this question. It's not far from being the correct answer in this question. Because, of course, over here too, in impetigo, we are having what is actually one of the most common cause of bacterial infection in children. It is contagious and also affects the superficial layer of the epidermis, also caused by Streptococcus pharyngeus or Staphylococcus aureus. So all of these things are possible also in what? Impetigo neonatorum. And that is why over here, I believe Krok went in for what? For the neonatorum or impetigo neonatorum. So basically, this is also good. So now we can add even this to one of our diagnoses, our differentials for, in people or in children. All right. So here your answer is what? Is D. 3 weeks after a case of acute tonsillitis, the patient is still weak, innate subfebrile, his retromaxillary lymph nodes are enlarged, tonsils are flabby, stick together with arcs, purulent plaques in the lacuna. Then we have what? What is the most probable diagnosis? So if you're having a case of chronic and you are not treating it properly, what it means is that, and now they've now started developing into some crepes in the tonsils and now getting accumulated in the lacunae and things like that, tells you that this chronic condition is now developing into what? Into a chronic case. This acute condition this acute condition is now developing into a chronic case. And that's why over here, we are definitely looking at what? At a chronic condition. All right. The following indicators were calculated to analyze population health. This is Fifi's favorite questions when it comes to hygiene. population health and treatment quality in a cardiological hospital. Now, primary cardiovascular morbidity is 62%. Please take note of them. Primary cardiovascular, that means people suffering from cardiovascular disease is 62. The total people suffering from what? Cardiovascular morbidity is 483 point blah, 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 blah percent. Cardiovascular mortality, that means people who died as a result of cardiovascular disease are what? 10.9. Proportion of cardiovascular mortality, look at it. Proportion of cardiovascular mortality within total mortality is 67.0. So that means that they've taken a portion. Now, there are a lot of people who died, okay? But out of the people who died, a portion of the people who died are coming from what? From the total are coming from what? The cardiovascular mortality, and that is what? 67%. Good. Now, primary disablement caused by cardiovascular disease is 16.2 per 10,000 population. What indicator is an extensive value? That's why I was making some emphasis on some things. Extensive value. Now, we know what intensive is and what extensive is. But for the benefit of those who just joined us recently, when we say extensive index or extensive value, we are actually referring to what? To a subset. That is one out of many. One out of many. That is an extensive index. One out of many. Now, when we say intensive index, this refers to the entire sample or the entire set. It refers to the entire set. So now the question is that which one of these things that they've mentioned is an extensive value? That means something out of something. And what are you thinking about? Who can tell me? Something.
Mortality.
Come again?
Of cardiovascular mortality.
Cardiovascular mortality, I'm thinking about.
We are
Wait, what's
thinking
the
about.
question?
The question is
looking-
that we are looking for what? An extensive index or
Okay.
extensive value. Something
If
out
that's
of
the
something.
case,
Mhm.
if that's the case, then it means the proportion of the cardiovascular
Exactly.
mortality within the big one. The total
Exactly.
mortality.
Exactly. So please analyze it very well. Otherwise, you get confused with all of these things that you're talking about because all of them might look the same, but they are not the same. So we're looking at the proportion of the cardiovascular mortality within the total mortality. That is our extensive value or extensive index. I repeat, subset is termed as what? Extensive. The whole set is called what? Intensive. All right. So over here, we are looking at B as our answer. Good. We're having a similar question again. A 6-year-old child complains of frequent liquid stool and vomiting. On second day of the disease, the child presented with inertness, temperature 38, pulse, scaphoid abdomen, painful palpatory, painful sigmoid colon, defecation 10 times a day with liquid scar stool with mucus and streaks of green. What is your diagnosis? Who can tell me? This is what?
Shigella.
Shigellosis. So don't confuse this one with non-ulcerative colitis. Don't. Because they all look similar, but don't confuse it. And we've talked about it like only God knows how many times. So here we're looking at what? E as our answer. E as our answer. The institutions that take part in medical examinations include prevention and treatment facilities, Medical Board of Ministry of Defense, Medical Board of Ministry of Home Affairs, Medical Social Expert Commissions, Forensic Medical Board. What institutions are responsible for temporary disability examination?
MSEC.
Wait, don't go and say MSEC. MSEC, we discussed the last time that MSEC, this is what? Giving leaves.
So for temporary.
Giving leaves. The question is which institution are
This one is
responsible
sanitary and
for
prophylactic.
temporary disability examination? So definitely we are going for,
This
for the
sanitary.
prevention and treatment facilities.
Mercury.
Yes. We're going for
Sorry.
prevention.
Hygiene.
Wait,
I
why
did
is it
this.
not sanitary and prophylactic?
Brother Fifi, why are you quiet?
Good. So no, you know, Bra Fifi. I said Bra Fifi. Now I'm talking Bra Fifi. Yes, Bra Fifi. So now there's a case. Now we want to give. First of all, we want to give disability. I mean, we want to examine somebody with what disability. Now, if, for instance, a patient comes to us, okay, the person is sick, the person is not feeling well. Who do the person first of all come to? They come to us. They come to we, the doctors. So first of all, we have to first of all analyze them that if indeed these people are not capable of working or not. Do you understand me? So these are referring to we, the doctors, or we, the medical people who are in contact with these patients. So they come to us, we analyze them. Yes, you are not feeling well, so we'll give you an excuse, we'll give you a sick leave. And our sick leave is actually limited. Okay? Our sick leaves are actually what? Limited. Now, so we are responsible for, first of all, determining that, yes, this person cannot perhaps work or is a bit what? Indisposed. We are the ones that determine that. The medical board of ministry, he is in somewhere. Do you understand me? That one, this was defense. Home affairs, I don't even know what they even do, safe. Maybe they deal with internal problems, maybe. Do you understand me? So that's why over here, we, the medical social expert committee, they give the leave for 1 month and above. And even 50 minutes understand that maybe they even have even a limit. Maybe they even have a limit too. Maybe after 4 months, maybe they are done. So over here, we are dealing with what? Prevention and the treatment facilities. In other words, we are dealing with what? The doctors, the hospitals, because we are the ones at the prevention and treatment facilities. We are the ones there. So we, first of all, have to analyze these people. And that is why it is what? See, even though it is what? How do you call it? Hygiene there. You have to think a lot.
But Dr. Baha.
Sure, shoot.
Sorry for cutting in. The other question we discussed the last time.
Yes.
It said that the Medical Advisory Commission gives the leave after the Medical Social Expert Commissions examine the person.
Don't forget, this person has already gone on a leave for a month or so. And now they want to give another leave for the person. So if you want to now give another leave, first of all, now he's now in my care as a medical social expert. He's now in my care. He's now in my commission. He's now in my department. Do you understand me? So now, before now, we will now also release it to the next department. We also have to what? Examine this patient before we say, indeed, this person needs more days. I hope it makes sense. Okay. Fifi, are you okay?
We go take him like that.
Anyways, this is hygiene. Hygiene. Don't take it personal. Don't take it personal for hygiene. Hygiene there. Don't take it personal. But don't worry, we'll come to it when we are done. Okay. If someone still have a question, we can come back to it. Now, after a lengthy march, an army regiment has set camp for 3 days near a settlement. Sanitary hygienic investigation detected several water sources. Okay. Now choose the source that would satisfy the demands for potable water. Demands for potable water. Definitely, if you look at all of these things, rainwater might not be potable because it is overly exposed. Maybe melt water could be, but for the whole population, how many times are we going to do all those things? Rivers don't even go there. So over here, we are looking at the well. Something stationary, something we can, put some, perhaps this infestation inside or whatever it is to make sure the water is kind of what? Potable for us or hygienic for us to drink. and then we do all the needed things that we need to do, covering it up and things like that. So from the source that we are having, the most appropriate that could meet the demands of the army and even the entire population could be what? Could be the well, or the artesian well, popularly known as the well or well water. All right. Clinical statistical investigation was performed to determine efficiency of a new pharmacological preparation for patients with ischemic heart disease. Again, this kind of things you already know it already. So, what parametric test can be used to estimate reliability? Don't forget, you want to determine the efficiency of a new pharmacological preparation for a heart disease. Good. So that one we use what we call the student T distribution. The student T distribution, or the T distribution. That we normally use. We've discussed this like 100 times, but again, for the benefit of us who are just joining in for hygiene, let me just go over it briefly. So basically, the T distribution is the probability. It's a probability distribution that is used to estimate population parameters when the sample size is small. When the sample size is small, or when the population variance is unknown. When the variance is unknown. And basically, connecting it to this particular question, whereby we have to determine the efficacy or the efficiency of a drug with respect to what? Some patient. Now, these people with the ischemic heart diseases, we're not too sure if they are that a lot. Okay? There might be very, very few people, isn't it? But we also want to determine the efficacy or the efficiency of this pharmacological drug. And that is why in statistics, they use the T distribution. They use the T distribution, aka students distribution. So over here, your answer is B. Your answer is B. Don't tell me how it's done, because even me, I don't know. A 30-year-old parturient woman was delivered to a maternity. Someone's microphone is on. Yes, I think it's Dr. Blessing. 30-year-old woman, parturient woman, was delivered to a maternity hospital with a full-term pregnancy. She complains of severe lancinating pain in the uterus that lasted 1 hour ago. Nausea, vomiting, cold sweat. Announces states that cesarean section was done 2 years ago. 2 years ago. Uterine contraction stopped. Skin and the mucous membranes are pale. Heart rate is 100. BP is 90, 60. The uterus has no margins. Please, it's not one word. It's the uterus has no margins. And it's sharply, this is Nene's favorite question anyways. It's sharply painful. No heartbeat can be auscultated in the fetus. No heartbeat can be heard. Moderate bloody discharge from the uterus can be observed. Uterus cervix is 4 centimeters open. Presented part is not visible. What is the most likely diagnosis? First of all, who can give me 2 differentials for no heartbeat of a baby? Or when the heartbeat, come again?
Uterine rupture and then abruptio.
Uterine rupture.
Good, an abruptio.
Mm-hmm.
Of course, if you see abruptio presentation, you will know. But this is definitely what? A rupture. So definitely your answer is D. Now, I ask this question because when you are reading a question and you already have something at the back of your mind, it helps you to stop making some silly mistakes, if I should put it that way. All right. A parturient woman is 23 years old. Internal obstetric examination shows the uterine cervix to be completely opened. Fetal bladder is absent. Cephalic presentation is observed in the plane of the small pelvic outlet. The sagittal suture is at the longitudinal section of the small pelvic outlet. Okay. Small fontanelle is situated closer to the uterus? What cephalic position will the newborn have during birth in this case? Now, when it comes to this question, when it comes to all these lie, like that, we need
That's
to,
positioning.
yeah, the position, yes. No, but don't forget that we have it's okay. You let me just explain some few things for you guys to know. There's difference between positioning and fetal lie. Very big difference. But in all, we call them fetal orientation. So for fetal orientation, we describe it according to the lie. We describe it according to the presenting part. We describe it according to the position. And we can even describe it according to the attitude of the presenting part. Very, 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 very what? Interesting. And even we can describe it according to the station. To the station. And this is a whole thing that, if you try to understand it at once, maybe you might get confused even more. But I'll do my best. So now, when we talk about the lie, or the lie. So the lie actually refers to the relationship of the fetus with the mother. Relationship of the fetus with the mother. And as human beings as we are longitudinal. That means from front to top. Longitudinal. That is how we are. So if the baby inside the womb is also just like the mother, or is it's also standing like the mother is standing, we call it what? A longitudinal lie. So longitudinal lie, we say the fetus is in the same axis as the mother, and this is the common one. That is longitudinal. The baby is just like the mother. Then we also have what we call the transverse or the horizontal lie. Transverse or horizontal line, which means that now the fetus is now 90 degrees to the mother. So you can picture it in your mind. Fetus is now at 90 degrees. So then imagine Kalila is standing, okay? And Nene has come to lie on the floor. That is how the baby is. I hope you guys are picturing something. No? So that is horizontal. And sometimes the baby lie in a horizontal or in a transverse manner, which of course no mother will want that to happen to her. No mother will want that to happen to her because it's difficult to bring them out. Then we now have what we call the oblique lie. The oblique lie. And in the oblique lie, the baby is about 45 degrees angle to the mother. So the person is not actually horizontal, but actually what? 45 degrees. 45 degrees. So that is what? The oblique lie. Now, like I said, if we want to go into the positions and things like that, that's where we will start. We'll end up talking about the anterior posterior or posterior anterior, and all of those kind of things comes to play. So that is more or less deals with the positions. But over here, we want to focus our minds on the lie. Let's focus our mind on the lie. And normally, the sagittal suture. Normally, the sagittal suture. Now, we talk about the sagittal. That is the should I say the mesh or the suture? Good. The suture that connects the parietal bones together. That is the sagittal suture. So normally, the sagittal suture are usually in the left and in right oblique. Anytime the baby is in the occiput anterior or occiput, sorry. Let me not confuse you guys because it's a whole lot of things. Let me just write it down so that it will be easier for me to explain. Good. So we are saying that the sagittal lie of the baby, okay, usually it must be how do you call it? Either left or oblique. So we have like this. The sagittal line must be like this. Okay, so either one is on the left if you're looking from the screen. So we have the left oblique, then we have the right oblique. So this is the, how do you call it? The sagittal suture. This is how it's supposed to be. Either left, either it is here, like this, or like this. And this is what? Oblique position. This is oblique position. And of course, the left one corresponds to a position of the baby. And that position is the right occiput anterior. Right occiput anterior. Right occiput anterior. What it means is that the occiput, that is like the back of the head, the occiput is anterior. The occiput is anterior. In other words, it is facing outside, or it is facing the pubic symphysis. If we say posterior, that means that the occiput is facing the mother, or the mother's back. So anterior means it is facing the mother's stomach. I hope I'm making some sense. Anyways, now over here we have so the opposite will be true for the left occiput anterior. And these are the normal lie for a baby. These are the normal lie for a baby. Normally, this is how it's supposed to be. So anything contrary to this, then we are having slight problem, depending on the severity anyways. We have problem depending on the severity. So therefore, over here, so that means this one means that this baby is in what we call longitudinal position. Because longitudinal is the normal lie. Okay? And the position is right occiput anterior or left occiput anterior. And the suture in right occiput anterior must be oblique, or left oblique, then right oblique. I hope I'm making some few sense. So anything contrary, then we have the reverse will be happening. So in the case where we're having the longitudinal section of the sagittal suture, that means this baby could be in an oblique lie. Could be in an oblique lie. But again, it depends on the angle of oblique. It depends on the angle of oblique. And that's why we now have the major and the minor oblique. Major and the minor oblique. But I'm not too sure why this one is minor oblique. Maybe, I'm not too sure. Like I said, I'm not too sure. So maybe the minor oblique has to do with the fontanus position in the uterus. Maybe. But I'm here to clarify that with a gynecologist. Okay? I mean, with an obstetrician. I'm yet to know some of these things from my bosses. Then when I get to know some of these things, then it will help me in future explanation when it comes to the different types of the minor and then the major oblique. For me, all obliques are obliques, but then there are differences between them. So over here, this should actually be minor oblique, minor oblique, minor oblique. It's a whole lot of things about this question. A whole lot of things about this question. But what I'll do is this. Find time, try and read on some of these things, talking about the oblique and longitudinal and the transverse and how to, because when the baby or when a mother comes, first of all, you have to determine the position, determine the lie of the baby. That's why we have the fundal area. You have to check the fundal length. You have to check the fundal grip. We have to check the lateral side to see where all of these things are. So all of these things, it's a whole lot of things. Sorry, guys. It's a whole lot of things that you have to look at. Then, of course, we talk about the presenting part. It tells you that whether it is the leg that is coming, it is the buttocks that is coming, or the butt that is coming. Is it the shoulder that is coming? Is it the back? Sometimes their back will even show that it's coming. So that's where we have the different type of the presenting type or the presenting part. So all of these things, they all come to play in helping us to know the position, the lie, the station, the blah, 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 blah. All right. So guys, this is what? D. This is D. This is D. All right. So, but of course, someone has more to add up. We'll add it up later on. All right.